I came here trying to figure out kind of what value could I provide to this conference. And I think one of the unique things that I kind of have from a situational standpoint is that I am the director for data science and AI for the emergency department at Yale New Haven Hospital. And within that environment, we see a lot of AI products. We have to make a lot of decisions about which ones to potentially implement, which ones to even start to think about from an evaluation standpoint. And I think a lot of kind of questions have come up, and we, I think, get to see kind of at the forefront of where we're going from an AI perspective. So I think most of that has been covered. Just from a disclosure standpoint, I do receive some funding from various NIH agencies and also some industry funding from Beckman Coulter, and I'm an advisor for Vera Health. But I thought we'd start with kind of where we are on the AI hype cycle. Interesting enough, as I was coming down on the train this morning, I was reading somebody's post on LinkedIn, and they had just been to the Radiologic Society's North American Conference. And they were commenting on the fact that it felt like just the Wild West when it came to AI products. That there were numerous products that were being put out there that didn't have clear, substantiated evidence behind them, that they were touting that they were actually delivering particular care models. Even to the point, I think, that some of the vendors that were there were putting FDA stamps of approval on their kind of vendor areas, and they didn't even have FDA approval at the time after secondary checks. So I think that is pretty high on the AI hype cycle of kind of where we are at this point. And I'll personalize it a little bit and kind of tell you about kind of what we see within the emergency department and kind of the products that are coming downstream for us. We see a lot of products that have a good idea, but have very little data to support that idea, and have almost zero to no outcomes to support that as well. I don't actually blame the vendors for that. There are huge barriers, and we're going to talk a little bit about that, of getting data and showing evidentiary support for these products. But that's kind of where we are, and it puts us in a very kind of unique kind of a conundrum of a spot from the standpoint of kind of figuring out whether these products are going to be able to be put in place and what they're going to do for our patients moving out of that. And the problem is that the consequences of this kind of misaligned AI are pretty significant. So when a vendor comes in to us and is asking to potentially entertain us implementing their solution in practice, it has to go through several different kind of steps within the hospital or institutional environment. So one, we need to figure out what IT resources need to be dedicated to implementation. We have physicians that need to be able to review the product, go through all of that assessment. There are going to be IT leaders that are going to need to assess the product as well. So there's a lot of just manpower that needs to go into overall assessment. The other aspects of this, and I'll move down to the kind of harm aspect, is that if we put in a product and we haven't really kind of put it through the ringer, it has the potential to cause harm. People think, oh, well, if it's only making suggestions, what's the disadvantage of that? But the problem is that I think often people forget about all of the downstream consequences that can come from these products. And in addition to that, there are potentials for worsening disparities in this. I'm actually probably more of a believer that AI has a lot of opportunity to decrease inequities. I think we've seen that through some of the kind of triage work that we've done in the AI spectrum. But there are, if the product has not been well vetted to make sure that it's not going to cause these disparities, you have a significant problem. And then the last part of this, and this is part I really worry about in healthcare right now, is that there's this issue of eroding trust within the system. It's only going to take a few products that are going to fail within the system, a few physicians and cases where the AI product goes wrong and the physician gets blamed, because let's be honest right now, all of the kind of legal risk is still at the physician-clinician level at this point. And so I think we really have to think about what products we're putting into place, because ultimately, I think we want good AI products in, and we don't want to erode the trust that's there and kind of the overall good feelings that exist at this point. So these are some of the barriers to success that I see kind of right now in AI. So there are big integration challenges. I think one of the things we see with a lot of these products is, they have been developed outside of the healthcare system. And there has been, a lot of that is because it's really difficult still to get products into the kind of healthcare space from the standpoint of working with EHR vendors and doing all of those integration aspects. The second part is I kind of mentioned was the regulatory and ethical aspects. I think that there's just right now there's so many products that are being generated. It feels like the very beginning of kind of the digital health space when we were seeing a lot of consumer-based apps. We're, I think, in that space now where there's just an overload of kind of AI products, and the FDA and other kind of regulatory agencies are really having a hard time to keep up. And that's creating this kind of bottleneck where companies are really wanting to get these products out, but they don't have the regulatory backing behind that. And then we see kind of this mismatch between the two. The third part about this is the poor industry academic collaboration. A lot of times the products that we're seeing being offered us, there hasn't been any real reach out or success for kind of working with academic or even just healthcare institutions with the development of that product. And again, I don't necessarily blame kind of the vendor product standpoint about this. I think there have been long kind of barriers from an institutional standpoint in working with companies to develop products, and that comes from the standpoint of patient engagement, clinician engagement when developing these. A fourth aspect is data access. I think this is getting better. We're getting kind of aspects of like quality assurance labs, a lot of de-identified data sets that are coming out there, but for a long time it was really difficult to get access to data within the healthcare environment. And then probably the one that I'm most interested in is this lack of rigor around evaluation. We are just not seeing products that are coming in that have had rigorous evaluation through randomized controlled trials that are focused on patient-centered outcomes. And it would make the decision very easy for me if I had saw a product that actually had those things in place to kind of purchase that product and move forward with those things. So I want to give you just one example because I think hopefully this will illustrate some of the complexities and how these kind of product decisions are being made. And so we'll talk about the emergency department boarding crisis. I'm sure probably most of you all have read, we have a serious problem in the United States. Actually, it's a global problem with patients boarding in our emergency departments. And what that means is that patients are sitting in the emergency department waiting to go up to be admitted into the hospital. They're taking up bed space. It creates all kinds of crowding issues. And there are a lot of downstream consequences for patients. We know that people that are boarding have worse outcomes. And one potential kind of solution around this is to think about looking at this from a deterioration index. So you probably have seen these in other spots within the hospital environments. Particularly, I think a lot of these deterioration indices were rolled out in the inpatient environment. But now the thought was, can we bring those down into the emergency department for all of these boarding patients? And because of the fact that ED nurses are preoccupied with a lot of other things, there's a real risk that patients that are in the emergency department decompensate over a short period of time, and that they go to the wrong either floor or care area within the hospital. And I'll give you just this anecdotal story. So this is a 63-year-old female submitted to the floor. She had cough, fever, had a diagnosis of pneumonia. You can see that her vital signs when she was actually transferred to the floor were pretty bad. And then she was subsequently transferred to the ICU. And this, we've been working with a company that's in this kind of game of looking at deterioration index, and they provided this as a particular example. And they noted that the threshold for the status for deterioration was exceeded, and that at the time there would have been a 1 in 5 odds noting that that patient would have been transferred to the ICU. So this was their example. This was how they were trying to kind of say, you should definitely adopt this product within the emergency department. But this is the problem with this product, and I think a lot of these kind of issues, is that when you really get into looking at the kind of performance characteristics, a lot of issues start to arise. So I'll just focus you down into the last line. And these are at different thresholds across the deterioration index. But if you'll notice, there's about 50,000 total patients. Out of those, there are 47 that are detected as being true positive, so that they were admitted to the floor, but eventually ended up into the ICU. And those were the true positives that were detected by the deterioration index. The problem is that there are 917, or almost 1 in 20 ratio of people that are being false positives or recognized falsely as needing that. And so the issue becomes, well, do we have the manpower and capabilities to be able to review 1,000 patients and potentially with a significant amount of those being admitted to the step down or ICU that don't really need to go there. And there are other issues as well with this. The other thing you'll note is that there are a significant amount of false negatives, so 350. So the tool is actually missing 80 to 90% of the people that go on to going from the floor into the ICU. And this, I think, to me, is probably the most troublesome part about this, and the part where I worry about kind of patient care aspects, is this kind of idea around automation bias. My fear is that if we develop or put this tool into place, that people are going to become incredibly reliant on the tool. They're just going to look at the deterioration index. They're not going to pay attention to anything else. They're not going to use their actual clinical judgment. And then the tool is bad. Like, it's missing 80 to 90% of people in that space. So I think some of this has to do with education and how it's used, but there are real kind of pluses and minuses to this. It's not just as clear as, oh, this is a great anecdotal case. We can move forward because it picked up this one person. So what is kind of a pathway forward that we can take here? From the standpoint of kind of greater collaboration from industry and healthcare institutions, I think this is somewhat happening, but I'd love to see more and more. I'd love to see institutions set up incubators to help companies really kind of get into this space, to test out their ideas and products before moving forward with them. And I think that would make it a lot easier to, from an evaluation standpoint for others when they were going through. We really need funding for these products that, for the evaluation. Like, when I talk to people and I said, oh, we'd love to look at this product, but we need to evaluate. We need to do a randomized control trial. We need to be very rigorous about how we do that. Nobody has the money. The hospital doesn't have the money. The company doesn't have the money to be able to fund that type of product and evaluation within that. The other aspect of this is kind of a holistic evaluation. So what I showed you within that example is that you can't just look at one or two things. What I didn't talk about is like all the other downstream things that you potentially worry about, like all of those patients that are going into the ICU and into the step-down areas of the hospital that didn't need to be there. What are the costs associated within the healthcare institution, and how can you measure that within these products moving forward? We definitely need better open platforms for rapid development. I struggle with this as a researcher, and I know companies are struggling with this as well. Like, we just don't have a great way to plug and play into a lot of healthcare institutions at this point, and we need to do better because I think it will help facilitate a lot of these other things. It'll decrease cost. It'll make it easier to evaluate. We need transparent AI standards, like what actually counts as a good AI product. And then, ultimately, we need a lot of stakeholder involvement and engagement with this. I mentioned, a lot of these projects are developed kind of without talking to nurses, talking to clinicians, and figuring out like what actually is the problem. And I think we need to open up this kind of system to let those things happen better. So I think that is it. Hopefully I didn't run over time, but I appreciate being here.
Thank you.
And I'll see you all later.